Good evening, sir.
Good evening, Shivang. You able to hear me clearly and also
Yes, sir.
see?
Yes, sir. Yes, sir. It's perfectly fine, sir.
Okay, great. That is absolutely brilliant, and I can see that.
Hello, good evening, Dr. Pavan.
A very good evening, Dr. Sharma. Pleasure meeting you once again.
Thank you, sir. Looking forward to it.
Yes. Thank you so much for sparing your time for today's evening. We really appreciate your kind gesture.
Thank you, sir.
We are filled with gratitude because this is the platform where we learn from you. Right?
Thank you, sir. For giving me the opportunity to be a part of this scientific feast. Looking forward to it, sir.
Our pleasure and honor, Dr. Sharma. We'll be starting another 2 minutes max. Basic some housekeeping I need to check, and then we will just initiate the webinar. Okay.
Thanks, sir.
Thank you. Really appreciate it. Yeah. So, Shivang, all this background and slides are fine. All done, right?
Yes, sir. Yes, sir.
Okay.
We are ready from our side, sir.
Okay. Perfect.
You can start when you.
Okay. Perfect. That's good. Absolutely brilliant. Allow me 30 seconds and then we start. Right.
Sure, sir. Thank you.
Yeah. A very good evening to everyone. I'm Dr. Pavan K. Gupta, part of the National Ayush body as Web Secretary and Secretary for Haryana branch of Indian Association of Occupational Health. Deep pleasure to get this opportunity to moderate this webinar. 108th webinar, a very auspicious number in our Hindu mythology, as we know. It's I'm thankful that our Vice President, Dr. Kamla Fartyal, and other esteemed panelists are also present. Very good evening, ma'am, and very good evening to all the panelists, and a very good evening to all the attendees as well. Thank you so much for sparing time today evening. So I was getting to this INOX environmental and occupational health DG Connect initiatives. 108th webinar we are conducting today. I'm repeating this number because we have come across a long journey, and we have been trying to be consistent. This has been a great initiative by Delhi branch of Indian Association of Occupational Health, driven by Dr. Gajendra Kumar as president and honorary secretary Dr. Sandeep Sharma from Indian Oil. A tremendous task that they have accomplished, taking this journey this far. We all are privileged and filled with gratitude for all that has been done and the knowledge bank that we have today on our e-platforms. So a very warm welcome to all once again. And with this, we are beginning our 108th webinar episode of our webinar on of ENOC initiative, as we call it, under the auspices of Indian Association Indian Occupational Health Delhi branch, AEO HD. With that, I would like to quickly welcome our speaker, esteemed speaker of the day, Dr. Nagender Sharma. And we can definitely very well see his brief profile on the screen. But yes, I will be elaborating more on his accomplishments, achievements, and his journey in the medical field in a while. And before that, just wanted to quickly mention some housekeeping rules. We will have the presentation from Dr. Sharma first, and then we'll have open the floor for question and answer sessions. You can, in the meantime, put your questions in the chat box or Q&A, send to me directly on my WhatsApp or to the secretariat. So this is what we usually elaborate so that you feel involved, that we all are part of a continuous process and also this knowledge feast. Most of the questions will be taken. Our endeavor is always to take almost all the questions that come to the platform. In case any questions are left, you will get an opportunity to reach out to Dr. Sharma to us later on. With that, I thank AUSD for giving me this opportunity to moderate the session. Definitely a great privilege to be part of it, and also as one of the key moderators for all these webinars, and it has been an absolute pleasure. With that, welcoming Dr. Sharma once again to you, and please allow me to read out your accomplishments and your journey in the medical fraternity. Dr. Sharma is a principal consultant, medical oncology, Max Super Specialty Hospital, Saket, Gurgaon, Max Hospital. Today's webinar, definitely topic that we are going to cover is on lung cancer management, what physician needs to know, a very apt and a prominent topic for physicians of this fraternity. So quickly touching upon the IOH, if I say 3,000 member strong body of and key drivers of the workforce of the organizations which are contributing for India's economy, if I say Maharatna, Navratna, Mini Ratna, and other public sector enterprises. So these physicians are actually the backbone of keeping them all on the move and taking care of their health. A very vast presence and also reach when we say Maharatna, Navratna, and Mini Ratna, and other PSUs. So we are actually addressing to a very large audience, Dr. Sharma, today. And this is not only this audience which is present right now, but this will go to our e-platform where it is open for the world as well. And we try to promote this and try to make it reach to many more people on our various platforms, whether it's WhatsApp, whether YouTube or Facebook or our other profiles. So this is how we are trying to pass on this knowledge to many more people apart from this physical online present of attendees and panelists here. So the reach is quite vast actually, and that is why we are very passionate, because it is not limited to this only this online platform as of now. So with that, I'm taking it ahead. Dr. Nagender Sharma is one of the best oncologists in Delhi for sure, as we know him. Dr. Sharma is working as a principal consultant at medical oncology, as I mentioned, at Max Super Specialty Hospital, Saket. Dr. Sharma has done his MBBS from Kasturba Medical College, Mangalore, Karnataka, and MD Medicine from Mahadeva Rampure Medical College, Gulbarga in 2011, and further pursued DM Medical Oncology from Cancer Institute, WIA, Chennai. He has worked as consultant, Department of Medical Oncology and Hematology, Medanta, the Medicity at Gurugram from Feb 2020 to August 2022. Associate Consultant, Department of Medical Oncology and Hematology, Medanta, the Medicity, Gurugram. DNB, Medical Oncology, National Board of Examination, New Delhi, 2017. DM, Cancer Institute, as I mentioned, from Adyar, Chennai, Tamil Nadu. Senior Resident, Medical Oncology and Hematology, Medanta, the Medicity. And the memberships that he has is Indian Society of Medical and Pediatric Oncology, Indian Cooperative Oncology Network, European Society of Medical Oncology, member of American Society of Clinical Oncology. I'm sure there are many more accomplishments and achievements, Dr. Sharma. It's an absolute pleasure to have you here with us today evening. Thank you so much once again. And with that, I hand over this e-platform to you for further deliberation and to listen to you. Thank you.
Thank you. Thank you very much, Dr. Pawan, for a kind introduction. I want to
Thank you.
extend my gratitude to the entire team of Environment and Occupational Health DigiConnect webinar and AstraZeneca for giving me the opportunity to be a part of this scientific feast. As we all know that we are living in an era in which the cancers are increasing day by day. We know that getting advanced cancer diagnosis, and that too lung cancer stage 4, it's not only devastating for the patient, it's actually devastating for the entire family.
Yeah.
The challenges which this patient faces, they are not only physical, they are emotional, they are psychological, they are spiritual, and above all, they are financial. There are a lot of research which have happened in the last couple of years as far as the lung cancer management is concerned. It is not only restricted to the chemotherapy, surgery, or radiation therapy. We have gone one step ahead. There are a lot of treatment in form of immunotherapies, targeted treatment. There are a lot of research which is going on in precision oncology, because of which the treatment of the patient is painless and it is patient-friendly, right? 10 years back, lung cancer in advanced stages, the prognosis was dismal. Majority of patients were not able to close one year after the diagnosis is established, no matter what we do with the limitation of science. But now we are moving towards precision oncology, have changed the management of the patients so much that we are talking about 5 years survival of advanced lung cancer these days, and majority of them we can treat them without chemotherapies. This is the beauty of oncology right now, and then lung cancer right now have gone many folds ahead as far as treatment is concerned. So purpose of today's webinar is how beautifully we can symbiotically collaborate with the physicians, how they can diagnose the lung cancer in a simpler way, and then they can direct their patients to the specialized centers or tertiary care cancer center where the best possible treatment can be given within the patient's reach, within the patient's geographical location. Because right now the oncology is widespread across the India. It is not only situated to Mumbai, Delhi, or metropolitan cities. Now there is a decentralization of medical oncology, hematology. We are having doctors who can take care of these diseases even in the tier 2 cities. So coming to the topic per se, lung cancer management, what physicians needs to know. So I will be covering this topic in 5 basic headlines. That most important thing is that epidemiology of lung cancer, what is the global burden and what is the Indian burden of this disease as of now, so that all of us will understand the litigations and what are the things which can happen in the next couple of years and where we are heading. Types of lung cancer and their survival. What are the basic types of lung cancer and how they are going to make a difference as far as survival is concerned. Management and recent advances in NSCLCs. What are the cancers which are resectable, unresectable, and metastatic or stage 4 cancers? What are the current unmet needs and how we can extend the survival of these patients for a couple of years or beyond within the limitation of science? And what is the role of general clinical practitioner as far as management of lung cancer or diagnosis of lung cancer is concerned? So general clinical practitioners, they are partner in management of lung cancer. They are the persons, or they are the doctors who catches the cancer at the grassroots level, because majority of lung cancer, the symptoms are very, very mild in form of respiratory symptoms like cough with expectoration, hemoptysis, breathlessness. Some patients can have chest pain, weight loss, wheeze. These are the symptoms because of which lung cancer majority times presents. So most important thing which you have to remember as far as lung cancer management is concerned is that most of the lung cancer treatment are costly and time consuming, and general clinical practitioners can help in counseling and decision making. So what is the role of general clinical practitioner in lung cancer management? The most important thing which you have to understand is that whenever there is a high index of suspicion of early and prompt diagnosis, as the lung cancer symptoms are non-specific and are more common respiratory symptoms, which I just enumerated. So we have to have a clear-cut viewpoints that these are the ways lung cancer can be diagnosed. Many times in India, we know that majority of patients who are having respiratory symptoms, they will have either the bacterial illness in form of tuberculosis, they can have viral respiratory illness, or flus, which we all know, but there should be high index of clinical suspicion, which is always there. right? So anything which is not fitting into the most common diagnosis, we also keep the lung cancer diagnosis in the back of mind. Optimal referral to the oncologist and pulmonologist is of utmost importance so that we can direct the patients to the correct doctors. In today's era, getting correct patient should come under the hand of correct doctor at correct point of time is very, very important. So unless all of us will symbiotically collaborate, then only we can give the best treatment to that patients within his or her limitation. So there's a brief the patients about the importance of the various tests. The patients have to be counseled properly regarding the importance of the various tests. Majority of the tests are very, very simple. There are a few higher investigations which can be done once we have done the diagnostic workup. I'll be coming to that later on. Taking care during the complications. So no matter even if the treatment is started, sometimes the general clinical practitioner's role is very, very important because they will be going to their tier 1 or tier 2 cities, and that time, if at all any complication in form of like pleural effusion is there, some chest pain is there, those symptoms have to be rectified. Then only the care will be extended to the grassroots level patients. And most one thing is the follow-up and the recurrence management. So even if the patient of lung cancer have taken the correct treatment by correct oncologist or pulmonologist, over a period of time, these patients bound to rebound in the way that there is a high likelihood of getting recurrences, which may be local recurrence or which may be distant recurrence. Much of the time, lung cancer spreads to 5 most common sites, as we all know. It can go to the brain, it can go to the contralateral lung, it can go to liver, it can go to bones, and it can go to adrenals, which is a cap-like organ just above the kidneys. So these are the sites where recurrence are more likely to happen. So all of this, we require a collaboration with general clinical practitioner as far as diagnosis is concerned and throughout the treatment journey of these patients. So where are we right now as far as cancer incidence and mortality is concerned? So there is a Globocon data which is published in 2018, which shows the percentage of new cancer and cancer death worldwide. It's in 2018, that is nearly 5 years back. So lung cancer, the incidence means the number of new cases which are diagnosed per unit time, which is annually if you see. So 11.6 is the incidence of lung cancer, which is on the top list, followed by breast cancer, 11.6, followed by colorectal cancer, prostate, and stomach in that order. And what about mortality? Mortality also is highest among lung cancer. It is 18.4% of all cancer death. That is approximately 1.8 million, right? So out of new patients, that is 2.094 million people which are diagnosed with new lung cancer, mortality is 1.8 million are going to die or succumb to the illness in next couple of years. So that's the unmet need, and we have to have a clear-cut answer to this problem. We have to address this by a correct management of these patients. In both sexes combined, lung cancer is the most commonly diagnosed cancer, that is 11.6% of total cases, and leading cause of cancer death, that is 18.4% of total cancer deaths, representing close to 1 in 5, that is 18.5, nearly 1 in 5 cancer death annually. So this is what, if 5 patients of cancer are diagnosed, one of them is going to die because of that cancer. So what about global data is there? What is happening in India? What is the epidemiology of lung cancer as far as India is concerned? It is the fourth most common overall incidence rates among cancer patients. It is the second most common cancer in males. It is third most common cause of cancer-related death in India, and most common cause of death in men with cancers. You have to remember this statistic is very, very important for all of us to know. The average age at the diagnosis of lung cancer in India is around 54.6, right? And this is still in 2021. And what we are seeing in our OPDs, whenever the diagnosis of cancer is established in medical oncology OPD, the incidence, there is an age migration. What is mentioned, it's actually we are seeing lung cancer even earlier age, that is around 40-45 years of age, right? So incidence is 5.9 and mortality is 8.1. That is what the unmet need, and we have to have a correct treatment in place to tackle this population of cancer patients, because otherwise we are going to lose them very, very quickly. Epidemiology of lung cancer, Globocon, which I already mentioned, these are the topics which will be coming. So lung cancer, tumor classification, which you have to understand. So lung cancer, tumor arising from the respiratory epithelium, the bronchi, bronchioles, and the alveoli. The major treatment is made based on the tumor classification. So by and large, we have to understand that lung cancer is broadly divided into 2 basic categories. One is non-small cell lung cancer, which is 85% common, and other is small cell lung cancer, which is 15%, right? So this is the basic thing which all of us have to understand, that the majority of patients will be non-small lung cancer, non-small cell lung cancer, and only 50% of patients will be small cell lung cancer. Even the non-small cell lung cancer, which is the most common type of lung cancer, it is subdivided into multiple subcategories. That is adenocarcinoma, which is the most common, followed by squamous cell carcinoma or epidermoid carcinoma, followed by large cell carcinoma, and there are other subtypes of non-small cell lung cancer, that is alveolar cell carcinoma, and list is long. But this is the minimum thing which you have to remember as far as NSCLCs or non-small cell lung cancer is concerned. 85% of patients will be of this category only. 15% of patients will be small cell lung cancer, and it is also subdivided into two basic categories. One is limited stage small cell lung cancer, and other is known as extensive stage small cell lung cancer. Although the percentage of this cancer is very, very low, it is 15%, but this is most commonly seen in chronic smokers who are heavily smoker. Small cell is rarely seen in those patients who are non-smoker, right? Small cell lung cancer, it is 15% of all lung cancer I just mentioned, and it occurs almost exclusively in chronic smokers, and it's more prevalent in women than in men. Small cell size cells that spreads or metastasize very, very fast, and that's why its name is small cell, and lesion most commonly originate in the central part of the chest, right? That's why small cell are majority times centrally located, and 15% of lung cancers are small cell lung cancer, and highly chemosensitive. You have to remember that they respond very well to chemotherapy, become resistant over a period of time, although the prognosis is very bad, but initially the response is very much gratifying to these patients because it melts like a snow when we deliver chemotherapy, because their Ks7, the proliferation index is quite high. They respond very well to chemotherapy initially, but over a period of time, the disease outsmarts the treatment, and then we have to start second line and third line treatment. Majority of patients will get poor prognosis. The most common type is non-small cell lung cancer, NSCLC. 85% of patients will be of this subtype, and NSCLC can be further classified by histology or molecular subtype. So 10 years back, we know that it is NSCLC is basically subdivided into adenocarcinoma, squamous, and large cell carcinomas, and some other uncommon subtype like alveolar cell type. Now, adenocarcinoma is further subclassified based on the molecular subtypes. There are some nearly 10 to 12 mutations which are already picked up, which are the driver mutations which drive this cancer. And if we are able to identify this driver mutation, we can target them with an oral pill or immunotherapy for that matter, and we can give or extend the survival in years, right? So most common mutation in adenocarcinoma, as it is the most common subtype. So a lot of research have happened on this subtype of lung cancer. So most common mutations which are seen in adenocarcinoma are EGFR mutation, ALK1 mutation, ROS1 mutation, BRAF mutation, HER2/neu, PIK3CA, ATK1, MAP2, K1, NRAS, RET, KRAS, and there are so many other unknown types which are also under evaluation, and they are the matter of research right now. Squamous cell carcinoma also, you can have EGFR mutation, FGFR1 amplification, PIK3CA mutation, DDR2 mutation, and there are so many other uncommon subtypes of that. So this is the way the pie chart is opening up. Now we are having a lot of options as far as treatment is concerned. More than 50%, more than half of the NSCLC adenocarcinoma, they are having a targetable mutation, as I already mentioned in this pie chart. Majority of patients I have already mentioned, it is EGFR or KRAS mutation, which is most common. So KRAS mutation is 25%. This mutation leads to increased tumor cell proliferation. EGFR mutation is 17% by and large. It drives the tumor growth and predicts the response to EGFR TKIs. TKI stands for tyrosine kinase inhibitors. ALK rearrangements enhances the tumor growth. These tumors are responsive to ALK inhibitors. The percentage is by and large 8%. And then there are other uncommon mutations which are already mentioned. Majority of times, you have to remember that 75% of patients of NSCLC, they are presenting in the advanced stages. So by and large, you can understand that 3 out of 4 patients we are getting diagnosed in stage 4 setting. This is what we have to understand, very, very important, because the earlier stage are by and large asymptomatic. So stage 1 and stage 2 rarely will get any patient unless they get an X-ray or a CT scan for other reason, right? Majority of patients will present in either stage 3 or stage 4. when patient becomes symptomatic and they come to medical oncology or pulmonologist, and they are getting diagnosed by the diagnostic and staging investigations, further treatment opens up. So one more thing which I want to highlight is the earlier stage. If the patients are getting diagnosed in the early stage, majority of the time the intent of treatment is curative. They are majority times are resectable. So nearly 25% of the patients of NSCLC patients are eligible for surgery. Surgery is the only curative treatment as far as lung cancer is concerned. So there's something known as neoadjuvant treatment, which is given in those patients who are potentially resectable to downsize the disease so that it will come into the previous surgery. Later on, they get operated and they get a treatment known as adjuvant treatment or adjuvant chemotherapy. Over a period of time, we have seen that stage 3 and stage 4, especially, why I am telling you that stage 3 also is subdivided into stage 3A, stage 3B, and stage 3C. So stage 3C and stage 4, majority of them are unresectable. Stage 3A and stage 2, stage 1 and stage 3B are majority times are resectable. So 75% of NSCLC patients are having an unresectable disease, right? So in those cases, the intent of treatment is going to be palliative or non-curative. Ultimate aim will be to keep these patients as good as possible for as long as possible within limitation of science. And these are the patients which are there in majority times in the medical oncology OPD. So in India, what we have to remember that fewer patients are diagnosed in earlier stages. That's why all of us should focus on the lung cancer screening. There's a low-dose CT scan, which is to be done in chronic smokers with 5 years of age. I'll be coming to that later on. So by that, we can detect the cancer in the early stages. So as this picture shows clearly, so in stage 1 and stage 2, only 3.5% of patients are getting diagnosed. Stage 3, 13.1% of patients are getting diagnosed. Stage 3B, it is 30.1, and stage 4 is 53.3. So more than half of the patients are getting diagnosed in stage 4. And if we club stage 3B, 3C, and stage 4 together, so 3/4 of the patients are getting diagnosed in advanced or unresectable stages. That's the unmet need. We have to diagnose these patients in early stage. If we do that, we can give them curative treatment. After treatment, these patients can live a cancer-free life. That is the challenge which all of us are facing, because in early stages, this cancer is asymptomatic. These patients are not having any symptoms. They never reach the hospital. There's one more thing which we have observed in the last couple of years. We all know that in 2020-21, the COVID waves were coming. That time, at a exponential level, the HRCT test was done in India just to find out the COVID CT scores, right? In that era, a lot of lung cancers got diagnosed incidentally just because they have underwent HRCT test and they got diagnosed in early stage, right? That's a blessing in disguise. So we have seen a lot of patients of lung cancer got diagnosed in early stage in COVID era, right? But that is not before that or after that, right? So we have to make sure that the current patients should get a HRCT test done if they are chronic smokers, and should get diagnosed if at earlier stages so that they can get a curative treatment and can live a cancer-free life. So overall, what you have to remember, overall survival of these patients. If you go and see, if you diagnose the cancer in the early stage, that is stage 1A or stage 1A2 or A3, 5-year survival is 92%, 83%, or 77% in stage 1 itself, right? I'm talking about 5-year survival here. Stage 1B onwards, the 5-year survival drops down to 68% in stage 1B, stage 2A it is 60%, stage 2B it is 53%. Look at stage 3A, it is 36%, and stage 3B it is 26% only. And I told you 75% of the patients are getting diagnosed in advanced stages, that is stage 3C, stage 4A, and stage 4B. And look at the 5-year survival. There is 13% 5-year survival in stage 3C, and stage 4A it is 10%, and stage 4B rarely or unlikely any patient is going to cross 5 years. This is what is challenging for all of us in medical oncology OPD. This is the medical facts which I'm throwing light upon. So how in a tertiary care cancer center like Max, Medanta, AIMS, or any other corporate hospitals or higher expertise where it is available, how these patients are getting managed? So there is a multidisciplinary tumor board approach by which we are diagnosing the patients, and we are discussing this patient across our doctors who will be sitting across the table, like in which the medical oncology tumor board is comprised of these basic 5 to 6 persons. One is pulmonologist, radiologist, pathologist, cardiothoracic surgeon, medical oncologist, the thoracic surgeon, the primary care physician, the nutritionist, and a counselor, right? So all will sit across the table. They will review the diagnostic investigation, staging investigation. They will take the patient's preference into consideration. It's not just the modality of treatment which is going to cure the cancer. It is the sequencing of the treatment which is ultimately going to cure this cancer. We know that majority of these patients requires multi-modality treatment approach. There is no one set of doctors who are going to treat this cancer completely. So you require inputs or expert opinion from the medical oncologist, radiation oncologist, thoracic surgeons, pulmonologist, radiologist, and nuclear physician who reports the PET scan, a qualified oncopathologist, cardiothoracic surgeon, and primary care physician. That is what is required as far as lung cancer management is concerned in a tertiary care cancer center. Management of early localized NSCLC, that is stage 1, stage 2, and potentially resectable stage, which is mentioned here is stage 3A. They are potentially resectable. So remember that these are the patients in which we can achieve cure, right? So how to address cure in these patients? Stage 1 and stage 2, by and large, remember that the patients of NSCLC who have disease limited to one lung and not involving the mediastinum or more distant sites, they are major times classified into stage 1 or stage 2. Stage 3 are those patients when the mediastinal lymph nodes involvement is detected in the patients and they are having symptoms also are classified as stage 3. So goal of early cancer treatment is cure. That's the bottom line which you have to remember. So if the patients are diagnosed in stage 1, stage 2, and stage 3 and stage 3B also, more or less we can achieve cure if we get the correct treatment at correct point of time. So standard of care treatment of the resectable NSCLC is surgery with the curative intent. A key role of multidisciplinary tumor board is to assess whether the patient is a candidate for surgery, right? One thing I want to highlight here is there is something known as operability and there is something known as resectability. They are not interchangeable. A cancer which is operable may not be resectable. A cancer which is resectable may not be operable. Why I am telling that is, operability is dependent on the patient's performance status and cardiopulmonary reserve and comorbidity burden, but resectability depends on the anatomical location, the site and size of the disease. A patient can have a resectable disease and may not be operable because of the comorbidities burden and poor performance status, right? If the patient is having ejection fraction of 20% in the heart and patient is having a performance status of 4, he's coming to OPD by stature, right? Not even a wheelchair. Obviously, these patients, even if they are resectable, they may not be operable. And sometimes the cancers are operable, but they are not resectable because they are encasing the major blood vessels. If the surgeons try to resect that, they will develop a torrential bleed on the table in the operation theater. That's why even if they are operable, they are not resectable. So that's why all the decisions, the attention to the final details have to be multidisciplinary tumor board, in which our medical oncologists, radiation oncologists, surgical oncologists will discuss, look at the scans, the PET scan, the MRI brains, all those things. This is known as diagnostic workup and staging workup. So I will just throw light upon the diagnostic workup. So there is something known as the lung biopsy, which is to be done. And on that, a higher specialized test known as immunohistochemistry, which will exactly tell us the subtype of the lung cancer. Based on that, we can do the molecular testing and to find out what is the driver mutation. This is known as a diagnostic workup of a suspected lung cancer patient. And second is known as the staging investigation, in which if we are sure that the patient is having a, suppose NSCLC, adenocarcinoma, and we know that the molecular oncology is telling us that the patient is having EGFR-driven lung cancer, we have to be very sure about the stage of the cancer. The staging investigations, majority of times, are whole body FDG PET CECT scan, contrast enhanced, and a contrast enhanced MRI brain. So majority of times, these are the staging investigation. In few patients, we may have to do the mediastinal staging, which thoracic surgeons or the pulmonologist can do by EBUS sampling of the nodes. So once the clinical stage is established and acceptability and operability assessment is done by the thoracic surgeon, the case is discussed in the multidisciplinary board. If it is resectable, neoadjuvant chemotherapy plus minus radiation therapy or neoadjuvant chemoimmunotherapy also can be considered upfront, followed by reassessment for the surgery and pathological staging, like once the surgery is done, the tumor tissue is out, it will be sent to the histopathology department, and the post-operative surgical specimen will come within 7 to 10 days, and that will throw light that what more treatment post-surgery patient requires, that is known as adjuvant systemic therapy or chemotherapy or radiation therapy. So you have to remember that there is something known as neoadjuvant therapy, which is given prior to surgery, and there is something known as adjuvant therapy, which is given post-surgery in these patients. The purpose of giving neoadjuvant therapy is to make the cancer resectable, right? Sometimes it is abutting the major blood vessel, which is not allowing the surgeons to operate. The role of the medical oncologist and radiation oncologist is to make it resectable so that it will shrink or melt, or it will come into previous surgery in the next couple of months. So molecular testing for EGFR mutation was not routinely performed on resected tumors until recently, after which a Dura trial came in which they have shown that if we use anti-EGFR drugs post-surgery, we are having a benefit as far as progression-free survival and overall survival is concerned. Outcome of early stage cancer depends on the surgery. Surgery is the primary treatment for these patients. Adjuvant cisplatin-based chemotherapy is recommended for resected stage 2, stage 3A, and selected case of stage 1B also. The results from the large randomized trial and meta-analysis show that 5-year overall survival benefit with adjuvant chemotherapy in patients with early stage lung cancer. The overall survival, OS stands for overall survival hazard ratio, is 0.89, and DFS, which stands for disease-free survival, the hazard ratio is 0.84. I just want to throw light upon what is hazard ratio. Hazard ratio just signifies that lesser the hazard ratio, better is the experimental arm. So lesser this value is from 1, more likely the patient is going to get benefit, right? As far as overall survival and disease-free survival is concerned. The unmet need is that overall disease recurrence and death following surgery and adjuvant chemotherapy remains high across all disease stages, right? As you can see, stage 1B, the 5-year recurrence rate by stage is 45%, even in stage 1B, which are called as early stage and localized cancer, in which the intent of treatment is curative. Even then, 45% of patients are going to come back with the disease within 5 years after standard oncological treatment. Regional localized disease, when you are in stage 2 or stage 3, majority of patients, like 62% of patients, are going to come back with the disease within 5 years after diagnosis and treatment. And 76% of patients in stage 3 are going to relapse or reoccur, whereas will be documented within 5 years in spite of standard treatment. That's the unmet need of thoracic oncology or lung cancer management is concerned. So adjuvant treatment with a TKI known as osimertinib, which is a 3rd generation tyrosine kinase inhibitor, which is approved for EGFR mutation patient of early stage or locally advanced stage of lung cancer, which have shown that those patients of stage 2 and stage 3A or stage 1B onwards, if we give osimertinib in the adjuvant setting, we are having a survival benefit as far as disease-free survival is concerned. Look at the hazard ratio. I told you that lesser the hazard ratio, better is the experimental arm. So the primary population, it is hazard ratio 0.17, and the median DFS, that is disease-free survival, hazard ratio 0.20 in stage 1B, stage 2, and stage 3A. So post treatment, we can give in this drug in an oral form in adjuvant treatment. So there is a 83% reduction in the risk of disease or recurrence or death with osimertinib, which is a 3rd generation tyrosine kinase inhibitor, which is available in oral form. Hazard ratio is 0.17, favoring the experimental arm, which is osimertinib. And there is a 80% reduction in the risk of disease, recurrence, or death with osimertinib. Hazard ratio is 0.20, and the p-value is less than 0.001, favoring that osimertinib is having a benefit which is clinically significant and also statistically significant too. Adjuvant osimertinib will provide a highly effective and practice-changing treatment for patients with stage 1B, stage 2, stage 3 EGFR mutant NSCLC after complete tumor section. Management of unresectable locally advanced NSCLC, that is stage 3 or beyond, when mediastinal lymph nodes involvement is there, are classified as stage 3. So goal of early stage cancer is cure. I already told you that, right? This is the way we classify in stage 3A, stage 3B, and stage 3C, depending on the nodal involvement, that is N1, N2, and N3. The approaches of management will be, we always have to discuss these patients in multidisciplinary tumor board, in which we can take inputs from our expert pathologists, nuclear physicians, radiologists, medical oncologists, and thoracic surgeons always, and radiation oncologists. And concurrent chemoradiation is the way forward as far as curative treatment is concerned in stage 3B, 3C. Followed, the concurrent chemoradiation is better than sequential chemoradiation, right? So both chemotherapy and radiation therapy are given concurrently. That is known as definitive CTRT, is the standard of care for stage 3 unresectable NSCLC. The survival rates, as you can see clearly, the survival rates following concurrent chemoradiation remains low. The overall survival rate following CTRT is 34% for 1 year, 2 years drops down to 13%, and 3 years 9% only. There is a significant clinical need for improvement in patient outcome for concurrent chemoradiation patients. The survival rates following durvalumab after completing concurrent chemoradiation, 1 year from 34% it increases to 83%. 2 years from 13% it increases to 66%, and 3 years from 9% it increases to 57%. So as you can see, if we use durvalumab, which is an immunotherapy drug, post concurrent chemoradiation, in those patients who have not progressed after concurrent chemoradiation, you have to document that patient is having a stable response, a partial response, or complete remission. If they are the correct right-fit patients, if we give this immunotherapy, durvalumab, over 1 year, the survival is prolonged. That's why this is the standard of care for stage 3 unresectable cancers who have been given concurrent chemoradiation followed by durvalumab. Right now, this is holding ground and it's the standard of care right now across the globe. So definitive chemoradiation, concurrent chemoradiation with radiation therapy followed by durvalumab is the new standard of care as far as stage 3 unresectable non-small cell lung cancer is concerned. Metastatic NSCLC. 3/4 of the patient, I already told that they are diagnosed with metastatic NSCLC. Majority, 57% of the lung cancer patients are diagnosed in stage 4. The treatment goal is to extend the survival, maintain and improve the quality of life, relieve the severe and debilitating symptoms, and limit adverse event as far as the disease, as far as the treatment is concerned. Ultimately, we have to keep these patients as good as possible for as long as possible within limitation of science. We have to extend their survival. We have to make sure that they live longer and live better in the little lifespan which they have. Stage 4 NSCLC, metastatic setting, it is called as M1A when contractile lung nodule is there, malignant pleura or pericardial effusion is there, or nodules, pulmonary nodules are there. M1B when single extrathoracic metastasis is there. Suppose one lesion is there in the liver or one lesion is there in the lung, that is single. That is M1B. And M1C is when multiple extrathoracic metastasis is there. Most common site, I already told you that it's brain, bone, liver, adrenal, and kidney. They are the most common site where lung cancer spreads. Diagnostic workup, right? So most important thing is adequate tissue for histological subtyping and molecular analysis is of critical importance or is of utmost importance. All patients with adenocarcinoma components should be tested for oncogenic drivers. It takes a week to be evaluated. The next generation sequencing may be used to detect a broader array of mutations and gene rearrangements. The rebiopsy at the time of progression from targeted therapy helps in determining the resistance in EGFR mutated and early positive cases. Liquid biopsy will be used. Sometimes patients are in poor performance status when they are coming to the emergency department. They are not having the minimal level of merit to get a adequate tissue biopsy. In that case, a liquid biopsy also we can do, in which we can take the sample of the blood and we can run all these markers, and by which we can diagnose this patient in a few patients in which the tissue biopsy is not possible because of the anatomical location of the site or the poor performance status of the patients. So remember that in oncology, especially as thoracic oncology is concerned, tissue is the issue, right? So if we are having the tissue, adequate tissue, we can use that tissue for carrying out the molecular analysis. We call it as NGS data analysis. NGS stands for next generation sequencing. We are doing it at our center, by which we can figure it out what is going wrong for this patient at a molecular level, and we can give a cancer-specific treatment to that particular patient. Current metastasis of NSCLC. So as far as management is concerned, the most important thing is chemotherapies, targeted therapies, or checkpoint inhibitors in those patients who are having a PD-L1%, which is a marker to check whether this patient is a correct candidate for immunotherapy or not. The chemotherapy is dependent on the histological subtyping for the cancer. The target treatment depends on the genomics, which is genomic driven, that is EGFR crossover, which is the most common mutation which are picked up, and checkpoint inhibitors, that is PD-L1, PD-1, and CTLA inhibitors can be given to these patients if they are right fit candidate for these drugs. Targeted therapies and immunotherapies have changed the treatment paradigm and have become a mainstay in the treatment of metastatic NSCLC with the oncogenic drivers and higher PD-L1 expression. The survival, which was earlier with chemotherapy only 8 to 12 months, that is, majority of patients were not able to cross 1 year when we are using only chemotherapy. Over a period of time, when we started using targeted therapies based on the genomics information, like Flora data is mentioned here. Flora data is for osimertinib, which I already mentioned, which is the anti-EGFR drug. This is oral pill, third generation TKI, tyrosine kinase inhibitor. Oral survival is published now, which is 38.6 months. And this is the median, right? Only 50% of patients will be able to reach beyond this, right? 38% or 38, this is in months. So this is more than 3 years is with osimertinib if the patient can afford it. And that is a drug which is already available in India. From 8 to 12 months, we are talking about 38.6 months on average. And now we are having even better drugs in which the overall survival is even beyond 5 years now, right? When we are combining chemotherapies or immunotherapies or targeted treatment together, the survival is even beyond 5 years. Or there are some drugs which are known as immuno-oncology drugs, like I already mentioned that CTLA4 inhibitors or PD-11 or PD-1 antagonists. When we are combining IO immuno-oncology drugs like nivolumab or ipilimumab, along with chemotherapy also, the survival is extended even beyond 5 years. The Keynote 024 trial, which is a trial for pembrolizumab, have shown that 30 months of survival is there for those patients who are having a PD-L1 expression of greater than 50%, right? EGFR mutations and their significance is what? EGFR mutations are categorized as either deletions, insertions, or point mutations. EGFR mutations as oncogenic drivers are detected in approximately 50% of Asians and 10 to 20% of Caucasian patients with non-small cell lung cancer. For India, EGFR mutation positivity rate is around 25 to 30%. That is, 1 out of 3 is going to be EGFR mutant, especially female patients. Most commonly found EGFR mutation in NSCLC is exon 19 deletion, which is from 42 to 50%, and L858R, that is exon 21 point mutation in exon 21, that is around 32 to 42%. There are some uncommon type of EGFR mutation like exon 20, exon 18, which are also there, but most commonly is exon 19 and exon 21 EGFR mutation. The EGFR mutations other than exon 19 deletion and L858R are considered as uncommon mutation like exon 18 and exon 20. For patients with advanced NSCLCs harboring exon 19 deletion or L858R exon 21 mutation, EGFR TKIs are used as a first-line therapies. So we can treat them without chemotherapies. We just have to give an oral pill, right? Which patient have to take at home. The hospital visit is minimized. They can meet us virtually, and the secondary cost of treatment is very, very less. This is patient-friendly, right? The frequency of mutation, exon 18 is 1.5, exon 19, which I told you, deletion 19 is most common, that is 46%. Exon 20, which is also uncommon, 4.1, or other exon 20 is 2.3. Exon 21, point mutation L858R and L861Q, it is 37.5 and 1.1%. The structural distinction of the first, second, and third generation EGFR TKIs, drugs like gefitinib and erlotinib, is the first generation. The second generation, apatinib and dacomatinib, and third generation is osimertinib. So, as you know, that first generation TKIs are reversible inhibitor of EGFR receptor, and second generation and third generation TKIs are irreversible inhibitor of this receptor. So, majority of the third generation TKIs crosses blood-brain barrier. So, those patients who are having the brain metastasis upfront, stage 4 NSCLCs, and they are having adenocarcinoma, we can use osimertinib because there is excellent brain penetration. It crosses the blood-brain barrier, and these patients respond very well to osimertinib, right? So there is a structural differentiation. I will not go into deep of that or depth of that just because of limitation of time. The efficacy of the EGFR TKIs for advanced NSCLC mutant NSCLC over a period of time, we have seen that from the PFS, that is progression-free survival, over a period of time from 9.5 months with third generation TKI have increased to 18.9 months with the third generation TKI. Right? There is a more than doubling, you can say, as far as the progression-free survival is concerned, right? So there is the NCCN guidelines, that is credible guidelines, because of which we are treating all over the globe. Medical oncologists are treating these patients of EGFR mutation, lung cancer, and NSCLCs. So osimertinib, which is the third generation oral TKI, is the category 1 recommendation as far as first-line therapy is concerned. Osimertinib has been given a preferred recommendation as far as first-line treatment of EGFR mutated NSCLC adenocarcinoma is concerned, and it is available in India. And the dose is tablet osimertinib 80 mg once a day patient have to take, right, till progression or unacceptable toxicity. other recommended drugs I already mentioned, erlotinib, bopatinib, they are also recommended, but it is preferred and category 1 recommendation as far as the standard NCCN guidelines is concerned. Advanced NSCLC with no mutate driver medication, this is the role of immunotherapy. So we are having a PD-L1 greater than 50%, then the option of pembrolizumab, which is immunotherapy drug, monotherapy is there, or we can combine this with chemotherapy, right? So pembrolizumab, pembrolizumab, cisplatin or carboplatin is the standard of care, or atezolizumab also can be given in those patients who are having a PD-L1 expression, which is a biomarker greater than 50%. If you are having a PD-L1 value of 1 to 49%, then we can use pembrolizumab, pembrolizumab, carboplatin or cisplatin, or you can use atezolizumab, bevacizumab, paclitaxel or carboplatin in this subset of patients. Summary of stage 4 cancer, you have to remember that over a period of less than 10 years, the treatment of metastatic lung cancer has evolved to the point that the previously universally fatal disease now has the potential to be considered as a chronic illness for a minority of patients. Despite these advances, most patients with metastatic lung cancer still die from their cancer within 2 to 3 years of diagnosis. This is what we have to remember that. So treatment can be considered as treatment only if it is beneficial, affordable, and accessible to the masses, right? To summarize, the most important thing which you have to remember about lung cancer is the overall 5-year survival of NSCLC is between 10 to 15%, primarily because majority of patients present with either locally advanced stage 3 or distinct metastatic stage 4 disease. Fewer patients are diagnosed in earlier stages. Also, as high as 30 to 60% of NSCLC patients undergoing surgery, those who are having early diagnosis, eventually develop metastatic disease. There is a need for improvement in neoadjuvant and adjuvant treatment options in the early stage in order to improve the outcome. Adjuvant osimertinib, which is a third generation oral tyrosine kinase inhibitor for EGFR mutant early stage lung cancer and also advanced, will provide a highly effective and practice-changing treatment for patients with stage 1B, stage 2, stage 3A, EGFR mutant NSCLCs after completion of tumor resection. The largest unmet need in early stage cancer can be categorized in 4 basic areas. That's improving the lung cancer literacy and awareness, increasing access to most innovative medicines, evolving how we think about the patient support to reflect increased survivorship in lung cancer, enabling early diagnosis of lung cancer. Currently, majority of them are diagnosed in advanced stages when the tentative treatment itself is non-curative and palliative, by implementing screening strategy for high-risk population and having a strong primary referral network so that the correct patient can be diagnosed at correct time under the supervision of a correct doctor. So there is a hope for a future with less lung cancer. This is what the bottom line is. The most important thing is the ultimate law of oncology says that you have to keep these patients as good as possible for as long as possible within the limitation of science. And we have to be optimistic. We have to look forward for the treatment of these patients. We have to make sure that their morale stays up, because these patients are undergoing a lot of emotional turbulence, there are lots of financial needs which we have to address. That's why there is an unmet need in which require a symbiotic collaboration with the general medical practitioners, so that they have to have a basic understanding in how the lung cancer management is concerned. It is done in a tertiary care center. Thank you very much for patient listening. And this is my mobile number. If at all anybody wants to be in touch with me, I'm always there. Thank you very much. Over to organizers, please.
Thank you so much, Dr. Sharma, for that comprehensive, very elaborative, and also detailed overview. Not just using these words, because every moderator has to use these words after the webinar, but I mean every word, because this is going to help many of us on this platform, and when we are going to promote this further on our e-platforms. There is definitely need for very early detection. That is the only emphasis that every oncologist keeps on telling on our platforms and everywhere. The sooner we do it, the better it is. We really appreciate that you have shared your elaborate thoughts with us on various aspects. You have also summarized, so there is nothing to summarize as such, but yes, few points definitely I'll mention from my side, which I took note. That great that you have shared the prevalences, which most common ones at the staging and also the category. This helps us identify at what risk the population is and how well we can support them. Thank you for that. 85% on the non-small cell one. The focus goes there for sure, and we definitely will take benefit of it. This is recorded. It will be available with us. We'll keep referring. Your mobile number is there. We'll keep bothering you. So hope you don't mind. We'll
No,
keep
I
reaching
don't mind.
you. Yes, thank you. Then yes, 5-year overall survival is the key for sure. 5 years are good years of life in the later part. If any person is able to survive that long, it's really, really great even after detection of cancer. So the focus goes there. Thank you so much. And then the multidisciplinary approach and the unmet needs part has been very elaborately and distinctly mentioned by you, which will help us take these messages forward. And that unmet needs section has identified very well where we have to focus when the patients approach or when we are in the clinical part and looking at it. Tissue is the issue, for sure, I have noted it. And yes, the message is quite clear. So with that, I think I have just one quick question in mind. So do you only take lung cancer patients, or other cancer patients as well can approach you and take your inputs and consultations as needed? A very generic question, please.
Right, sir. So as a DM medical oncologist, sir, we are trained in a prestigious institute like Chennai, Health Cancer Institute, Chennai, where I have done my training. And we are all well versed with treating all type of cancers, right? As far as medical oncology is concerned. So lung cancer, breast cancer, gynecological cancers like ovary cancer, endometrial cancers, or carcinoma cervix. Urinary cancers in form of urothelial cancers of bladder, kidney cancers, prostate cancers, GI cancers in form of esophageal, stomach, and the colon cancers, and brain tumors, and even so many types of hematological cancers. We are all trained how to handle this. Right? So I'm looking forward to a symbiotic collaboration. If at all my need is there, my number is there with you. So anytime you can reach out to me, and we can give the correct treatment to the correct patient at the correct point of time.
Absolutely brilliant. That was so we're probably taking your more inputs on other cancers as well. As in when we are able to, and as in when your availability is there, we will take your inputs on those. And secretariat is going to reach out today itself. I have referred something patient. Maybe he'll be reaching out to you. We'll see. So take your help, because they were asking me, and I think here's the answer. So we'll take it up. Moving quickly on to the questions. Audience has been quite proactive. They have already posted the questions. You also can see in the Q&A box. But I'll take the first question from Dr. Kulkarni, Dr. Sanjeev Kulkarni, one of the stalwart in occupational health. And he has asked, is co-carcinogen necessary to get a carcinoma?
Okay. It's a very interesting question which you have asked, sir. The point here is there are some set of patients who are more prone for getting cancer, right? So we call them the pre-cancerous state, right? So every cancer will not develop overnight, right? There is a chronic inflammation and chronic damage which happens over a period of time. So we all know that the smoking itself is an ecological factor, which is the most common ecological factor in not only smoking, the tobacco in any form is dangerous, right? That's the most common culprit, which causes chronic damage to the epithelium of the lung, right? Over a period of time, those that will cause proliferation, and it will cause an undisciplined growth of the cells. And over a period of time, they will get a precancerous state, and then they will develop early stage cancer, locally advanced, and metastatic. So no cancer reaches directly to stage 4. This is what we have to remember. And over a period of time, patient has to go from stage 1 to stage 2, stage 2 to stage 3, stage 3 to stage 4. Majority of patients are diagnosed in stage 4 just because they are symptomatic in stage 4. Right? Majority patients in stage 1 and stage 2, they will be carrying out their activities of self-care without any difficulty. They will be going to jobs. Right now also, as we are talking right now, there are so many persons who are working in offices, they are doing their jobs, they don't know they are already having stage 1 cancer, right? Over a period of time, they will present with the symptoms, and they will land up in medical oncology or surgical oncology or pulmonologist OPD, and they will get diagnosed. So that's the unmet need. Those patients we have to identify in society so that we can diagnose them in early stages, and we can give a potentially curative treatment at correct point of time and can give a cancer-free life to these patients, which they deserve.
Okay. Okay.
Right.
Perfect. Dr. Kulkarni, I'm sure that has provided an answer to your question. Moving on to the next question from Dr. Damodar Lele, one of the very prominent physician and from Snyder Electric, Mumbai, and very thorough attendee, and also a part of this ongoing webinar sessions. He has always been there, and his present has given us a lot of encouragement also. Dr. Lele, you can ask your question yourself if you want to unmute and ask, or else I can also read out.
No, there are two questions.
Perfect.
Can you hear me?
I can hear you. Yeah. Thank
Yes,
you
sir,
so
we
much.
can hear you loud
Please
and
go
clear.
First
Yes.
question is, what do you mean by screening? Because screening means, is it simply you go on taking X-rays every year or every 2 years? Because there is no other way by which you can detect lung cancer. This is first question. And second question is, histopathologically, if a tissue is different, will chemotherapy differ? If it is adenocarcinoma, something else, or small scale carcinoma, something else, something of that kind.
Absolutely right. So it's a very, very important question you have raised, Dr. Damodar. I just want to answer your first question first. So regarding the lung cancer screening which you asked. So lung cancer, first of all, we have to understand what is cancer screening, right? So cancer screening is a test. There are the battery of tests which have to be done in those patients, in those persons who are having an asymptomatic stage. We have to identify those persons who are likely to have a cancer. So this is something as population-based screening or mass screening. So lung cancer screening, coming to your point, so it is only for high risk persons, right? Who are the high risk now? Question is standing in front of us. Those persons who are between 50 to 80 years of age, those who are currently smoking or have quit smoking for last 15 years, or who have had at least 20 pack years smoking history. What is pack years? Pack years is number of packs of cigarettes smoked per day for a number of years, that is pack years. Suppose you have smoked one pack of cigarette per day for 20 years, so you're having a 20 pack years of smoking history. Or if you have smoked one or two pack for 40 years, there are also 20 pack years of history. So those patients who are currently smoking in the age bracket of 50 to 80 years of age and have quit smoking in the last 15 years, or having at least of 20 pack years of smoking history, they are the high risk population. So lung cancer screening is for those. Now the question is how to do lung cancer screening. Is this the X-ray? Is this the CT scan or PET scan? Answer is, as far as the credible guidelines for lung cancer as of now, the low dose CT scan is approved by NCCN, by WHO, and US Preventive Social Task Force, which is the credible guidelines for lung cancer screening, in which a low dose CT scan have to be done in a high risk population, which I just enumerated, right? By that, we can identify this set of patients in an earlier stage, correct? So correct age, correct population, and correct time, if we do that, and there are high likelihood of getting cancer diagnosis in early stages. This is what is the recommendation as of now. Point number two I want to tell you is that there are a lot of lung cancer patients who got diagnosed in the COVID era. I already mentioned, because HRCT test was done for getting the CT score. In last 2-3 years, we have seen that the waves of COVID are coming, because of which we got a lot of lung cancer in early stages, because they have done HRCT scan and the tumor tissue was picked up, the mass or radiopacity was picked up in the CT scan. When we done a biopsy, it came out to be lung cancer, and we have treated those patients, and they got a curative surgery, and they are living a cancer-free life right now. If they would have missed that CT scan, I'm very sure they would have get diagnosed in stage 3 or stage 4, in which the intent of treatment would have been non-curative and palliative. They would have lived their disease. They have to live their life with the disease and with the treatment in stage 4 setting. This is what the bottom line is. Coming to your second point, like if the histopathological subtype is different, suppose you're having a small cell cancer, or you're having a non-small cell cancer, which is the most common subtype, 85% followed by 15%, whether the choice of chemotherapy or the treatment is going to change. This was your second question, right? So answer is yes. The choice of treatment will change with the histopathological subtype. If you are having adenocarcinoma, which is the most common subtype of NSCLC, which is 85% of lung cancer, the choice of chemotherapy will be pemetrexed and carboplatin-based chemotherapy doublet, or pemetrexed or cisplatin, right? If you're having a squamous cell type, the choice of drug will change. You can use paclitaxel, which is taxane-based of chemotherapy, along with platinum, which can be cisplatin or carboplatin, right? We can use immunotherapy drugs. We are having a lot of options right now. We have pembrolizumab, we are having nivolumab, we are having atezolizumab, ipilimumab. They are all durvalumab. They are the drugs, immunotherapy drugs, which have changed the management of lung cancer like anything, right? We are talking about 5 years survival right now, right? So target treatment is based on the molecular analysis, the EGFR, cross-1, PD-L1, all those molecular subtypes which I told. So that will drive the decision. So these are the driver medicine. It is something like that. If you are driving a car, somebody is sitting on the driver's seat, right? So if I had to stop the car, I am not supposed to stop the car in the physical form. I just have to remove the driver from the driver's seat, right? Car will automatically stop gradually. So this is what the molecular oncology is based upon. So if we hit the correct patient with the correct molecular targeted drug, will just like a missile, it will go and it will block the receptor. It will cause cancer cell starvation, and over a period of time, the number of cancer cells goes down. They will die because starvation, and patient will have a better quality of life, and we can live longer and live better with this treatment. So if the patient is having an uncommon subtype like small cell lung cancer, which can be subdivided into limited stage small cell lung cancer or extensive stage small cell lung cancer, the choice of drug is entirely different. The drugs are etoposide and platinum, right, which are not used in NSCLCs, right? Etoposide and platinum means carboplatin or cisplatin, any of them, along with the etoposide or plus minus immunotherapy can be used as far as first line treatment is concerned. Over a period of time, the cancer cells will develop resistance. They will try to outsmart the treatment. Then we have to expose this patient to second line treatment. We have to do the biopsy from the suspected progressive site, and we have to treat them accordingly. And we may have to rerun the molecular test to find out is there any actionable mutation. So this mutation also can change over a period of time. The patient who is EGFR positive upfront can switch over to BRAF over a period of time after treatment. So we have to look for it, what is going on wrong at multiple level, and guide the treatment of the patient.
Thank you so much, Dr. Sharma, for taking the question very passionately and also providing answers to that. I am sure Dr. Lele's questions are answered. I move on to our panelist. I'm sorry, I should have gone to them first, but somehow I saw the questions on the screen and I was carried away. Dr. Ghanshyam Dulera and Dr. Tyagaraja Raju are with us, very prominent faces of occupational health in the country, and also very regular attendee of these webinars and key contributors, I would say. These people, they form backbone. So first to Dr. Dulera for his inputs and feedback. Dr. Dulera, if you can hear me, please.
Yeah, it is a very nice presentation. One question I just wanted to ask regarding that most of the lung cancer is diagnosed very late. By the time symptoms develop, it is already metastasis already been happened, because we lost one of our gastroenterologist friend who had basically he started developing severe back pain, and then when the MRI was taken, the secondary metastasis were found, and then when the PET scan, primary lung was found basically. So by the time treatment was started and surgery was also done, but he couldn't basically we lost him basically in within the 8 to 9 months treatment, post surgery, post chemotherapy. So that's why it is diagnosed so late. That is the one point is there. And second point is that basically how much contribution of the atmospheric pollutants are there, because that and then basically how much basically how it can be prevented. These are the main questions there.
Okay.
Right. So absolutely correct questions you have asked, sir. They are very pertinent points which you have raised. The most important thing, the sentence which you told is absolutely right, that 3/4 of the patients of lung cancer are diagnosed in advanced stages, right? Only 1/4 of the patients we are able to pick them in early stages when the patients are not having any symptoms, right? Incidentally, they get picked up if they had an X-ray or CT scan because of some other reason. So they get diagnosed, or if they are underwent or followed the cancer screening guidelines. So why it is happening is the God or nature itself have created human body like this. So brain, if you see, the most important part of our body is brain, right? It controls all of your structures. So it is the most important part is covered by a thick bony calvarium or a skull cap, we call it. So even if you are having a 1 millimeter or 5 millimeter lesion in the brain, it will manifest as symptoms like seizure, dizziness, headache, and you will get diagnosed in a very, very early stage, right? Then the second most important part of the body is heart, lungs, right? That also is covered by a rib cage, right? That also God have given that covering to that part. So, but that rib cage, that is little bit expandable, so the space is there. So many times you have to have a nearly 5 to 6 centimeter of tumor in the lung to get the symptoms. And that's the reason why these patients are getting diagnosed in the advanced stages. They will be having a nodal involvement, they will be having a local site or neighboring organs that will spread. And that's why these patients are getting diagnosed in the later stages. And that's holds good for abdominal cancers also, like GI tract cancers or gynecological cancers. So abdomen, there is no bony coverage, right? So they will expand, that's why this lung, the GI tract cancers or the colon or renal cancers are also diagnosed in even later stages, correct?
Yeah.
So this is the reason by and large, if you see, this is the structure of the body is like that, right? So,
Yeah.
and second thing is ignorance. Majority of patients will not follow the cancer screening guidelines. This is what the bottom line is, right? This is a hard fact which I'm telling you. Second thing is smoking is very, very prominent, very, very prominent in our country, right? Third is pollution. There are some occupational hazards like asbestos, and they are all because of their job, they are getting exposed to these drugs. And there is a different mechanism by which we call it passive smoking, right? Females are also getting diagnosed with lung cancer because the husband is smoking or the surrounding or vicinity where they are staying. That's why these cancers are diagnosed in both the genders, right? Small cell lung cancer, I told you, which is uncommon or lesser common subtype of lung cancer. Majority of, like, you can't have a small cell lung cancer without being a smoking history, right? It is so rare. Small cell lung cancer is usually seen in males because they're heavily smoker or because of their occupation, right? So that's why these cancers are diagnosed in advanced stages. When the prognosis is dismal, the longevity of life is limited and the cost of treatment is very high, right? So this is not only devastating for the patients, it's actually devastating for the entire family. These challenges which this patient face, they are not only emotional, they're physical, they're spiritual, they're psychological, and above all, they're financial. So over unmet need or over emphasis should be to diagnose this patient in early stages when the intent of treatment is curative and we can give a cancer-free life to this patient.
Perfect. Thank you so much, Dr. Sharma, once again for taking it up in the similar manner with all the passion. I think it was very important question which was asked, definitely, and a very distinct differentiation you have provided. This is going to help us, all of us, depending upon the way God has created the body and why these are detected late. Very, very, very basic question. It comes to everybody's mind. I think a very clear answer to that. Dr. Tyagraju, very good evening. Such an honor and pleasure to see you. And also, it will be great honor to hear you as well. As always, thank you so much for sparing your time. Please, over to you for your feedback, inputs, comments, suggestions. Dr. Tyagraju is from
Bangalore.
Yeah, Bangalore, yeah. He's from Bangalore and also a key contributor. Dr. Tyagraju, over to you, please.
Okay. Thank you very much, Dr. Pawan Kumar Gupta.
Sir.
And it is a very nice to hear from you. And
Yes.
Our very learned speaker, Dr. Nagender Sharma, beautifully spoke about the lung cancer, its diagnosis, its recent trend, and what are the pre-diagnosis, what are the cough symptoms, and all these things. Very beautifully he has elaborated, and later on he has gone into the how to detect the cancer, down to this one non-resectable cancer, how metastatic cancer, and even resectable cancer, everything he has told very informally, very beautifully, and in an academic way, he has expressed everything. And we are very much thank you. My hearty congratulations to AEOHD and also Haryana branch. Please keep it up, and so that people can learn from it, because nowadays, whatever we learn, we can implement it, because now everything is very vast and very this one. And now I think we are hearty congratulations to Nagender Sharma ji, and you have beautifully spoke about lung cancer. Very, very thank you.
Thank you so much, Dr. Tyagraju. Really appreciate your kind gesture. Gratitude for all your kind words. And these words are communicated in Holy Spirit to Dr. Sharma as well. Really appreciate. Yeah. So with that, Dr. Sharma, we come to an end of this webinar, today's webinar. We definitely have taken some more of your time, but it was worth it, I would say. And you can definitely refer to the recordings later on. Whenever you have time, it will be shared by the Secretariat, and then Secretariat will be in touch for more sessions probably that would be requiring your inputs upon. Really appreciate once again for your kind gesture of sparing time today evening.
Thank you very much, sir. And I want to extend my gratitude to the entire team of Environment and Occupational Health, especially to you, Dr. Pawan sir, and Dr. Gajendra Kumar, and all the panelists who have spent their time in Saturday evening and giving me the opportunity. I'm really thankful to the AstraZeneca and your team for giving me the opportunity to be a part of this insightful and thought-provoking scientific session, and looking forward to a symbiotic collaboration with all of you in future. My number is there with you. You can reach out to me. Thank you very much.
Thank you so much. And I would definitely will reach out. So have a wonderful Saturday evening and weekend, Dr. Sharma.
Thank you, sir. Thank you. Take care.
You too. Please, thanks.